because of impure thyroid. It's a non-RS product. So now many changes are happening, especially for metabolism and obesity range. So to take care of the metabolism, so Mr. Arun sir is there, who is our speaker of the day. So sir is a gastroenterologist practicing at Apollo Clinics Road, and sir has done many member in many associations. As you know, sir has done research in key publications, many publications. So here are the publications, list of publications sir has done it. So sir is the chief doctor in Apollo Hospital, one of the doctors, gastroenterologist and hepatologist. So I welcome sir for this wonderful session to take over from here, sir. Yes,
Respected all dear friends, really a great pleasure for me to be here, and even in busy weekdays in Wednesday, and we have been gathered here to discuss about one major important area. It's nothing but your fatty liver. Once a patient is going to land up with evidence of fatty liver, how are you going to approach this patient? I would like to make very simple and open to all. And at any point of time, you can
try
so why this fatty liver considering important scenario nowadays in India? So once a patient is going to land with evidence of fatty liver, what is the next step you are going to do? Whether the patient deserves diet, lifestyle modification, or whether the patient deserves any medication, what are you going to recognize? Or the patient is going to land up with worsening of changes? In case if the patient is going to land up with evidence of worsening of changes because of this fatty liver, how are you going to recognize the clinical scenario? What are the best line of investigations you are going to check? Which means in your side, if there is more than 5% of fat, it's going to be accumulated, which means the patient is going to land with evidence of fatty liver. In Indian scenario, for example,
sir,
if the patient
thanks for
coming, there will be any evidence of about 90 to 95, almost 100% of the population over the period of time being developed fatty liver. The problem in Indian scenario is we will be having two major events. One is alcoholic liver disease, and the second one is metabolic liver disease. When compared to the global population, in Indian scenario, alcoholic liver and metabolic liver is going in equal proportion. Even though the pathophysiology and all those things will be entirely different with your metabolic as well as alcoholic. Alcoholic liver, in initial phase, we will be knowing who are patients coming with liver complications, we will be thinking mainly because of alcohol. But now, the scenario has been completely changing. So we have been focusing on metabolic profiles. Initially, the terminology called non-alcoholic fatty liver disease being used. Now it has been completely revamped as a newer nomenclature from 2024-25. May be taken as metabolic associated steatotic liver disease. Why such change in terminology? Because non-alcoholic doesn't mean if the patient is not going to take alcohol, they will not have evidence of alcohol. Not like that. There are some evidence, even though if the patient is consuming a reduced dose of alcohol, the patient may have evidence of fatty liver with metabolic syndrome. That is what is called as MET-ALD. That's a metabolic alcohol liver disease. So these two entities is going to link together. To talk about metabolic liver disease, 5 major entities. So very important. We all know about what do you mean by the metabolic syndrome. If the BMI tends to be in the higher side. As we are in Indian scenario, if the BMI tends to be more than 2.5, we need to consider the patient for obesity. But most of the scenarios will be in the range of 3.0. Supermorbid will be going almost up to 40. Once a patient is going to have dyslipidemia, your change in glucose levels, along with if the patient is having hypertension, in the background of your HDL as well as your TGL, all those things, if it is going to be the higher side. With your waist circumference depends upon the criteria for men and women. If it tends to be more than 1 or 2 or more than 90, which is tends to be the highest side for waist circumference, that shows the patient is going to be in evidence of metabolic syndrome. Once a patient is going to land up with evidence of metabolic syndrome, the key important problem is the patient will be having multiple issues. Starting from head to foot, the patient will be having multiple presentations. The patient may have respiratory compromise, cardiovascular compromise, neurological compromise, sleep apnea, and the patient may have PCOD and all the multiple complications. But what is the major thing which creates a huge threatening to the day-to-day life is your metabolic associated steatohepatitis. It is one of the dangerous complications. We need to recognize this kind of presentation in earlier way. That's very important. For example, in case if the patient is going to land up with liver problem, metabolic associated steatotic liver disease, what is the most common cause of mortality? The most common cause of mortality mainly because of your cardiovascular death. Because they may SLD per se, not because the liver cirrhosis the patient is going to die. The main etiological trigger, the precipitating factor will be your cardiovascular risk. That's why whenever you are going to address a component in the liver, we need to address the component in the heart too. That's very important. So why I'm talking on all these things very importantly is, see, when you are going to address with such kind of molecules, we need to choose a molecule which does not affect the heart, which does not affect the kidneys, which does not affect any major organs. We need to recognize the presentation early. There are semiology of this kind of events to present. For example, if a patient is going to land up with evidence of fatty liver, you are going to do a routine ultrasound screening, you are identifying fatty liver. How significantly we are giving importance to the patient? Most of the time we are lacking. We are not giving much of importance, but that fatty liver will be predisposing over a period of time to your metabolic associated steatohepatitis. What do you mean by that? Which means the patient is going for inflammatory cascade if it is going to get happen. The patient may have inflammatory changes if it is going to get developed. Your ballooning, hepatocytic. These are all biopsy proven findings. Along with if the patient has enzymatic elevation, for example, if your AST8 initiated ISI, focus, but still there might be a huge deficit in this area, and only around 10% of the population will be addressed, and more than 20 to 30% of the population will not be addressed only with diet and lifestyle modification if the patient is having evidence of fatty liver. So this is what the problem. So the metabolic components, your various hunger hormones, your fullness hormones, all those things will be having a contributing factor for this. And starting for your therapeutic management for metabolic associated steatotic liver diseases, the basic line of molecule your vitamin E that has been well approved. So we need to target anti-inflammatory molecule and anti-fibrotic, lipid pathways, and all those things we need to address in molecules. So the use list, starting from your pioglitazone or metformin or vitamin E, in the background of your liraglutide or semaglutide, use list of molecules are there, starting from your saroglitazone to your resmetirom, use list of molecules are there. But when we are going to address this kind of things, the basic one, your metabolic parameters, your very weight loss along with your GLP-1, which is liraglutide being tried in the initial phase. Now your next generation incretins like your sema as well as your tirzepatide being checked in the much. This is what the basic outline. So you should remember this picture very importantly. So we need to target on steatosis, your inflammatory cascade, your insulin resistant pathway, and your liver fibrosis. So basically, there are a huge list of molecules in this area to get addressed. I'll be talking on each and what's very important. Today our area of interest is to talk on this semaglutide. What is the major mechanism of action of this semaglutide when you are going to use? It mainly will reduce your gastric emptying. There are more than 5 areas of interaction will be there. It's nothing but your GLP-1 receptor agonist. It's a monoagonist. When you're going to use your dual agonist like your GAP as well as your GIP, for example, your tirzepatide, nowadays there is one more thing that's being tried and recently it has been more acceptable. For example, the molecule what is called as retatrutide. It's nothing but your triple agonist. One is your GLP, and next to that your GIP, and next to that your glucagon receptor, in which you will be having significant weight loss with your retatrutide like molecule when you are going to consider. That's in the pipeline for treating a patient with NASH. So the major mechanism of action is in central pathway, your pancreatic pathway, hepatic pathway, as well as your indirect and direct pathway. So mainly it is going to augment your insulin secretion and reduce your gastric emptying, and the prolonged gastric emptying, what's going to happen? The satiety center is going to get very activated. For example, because of that the patient may have evidence of significant weight loss, and the appetite is going to get calmed down because of the CNS activation, and the liver receptor, the glucose production, liver fat is going to come down with the semaglutide. And the major mechanism induces weight loss, metabolic effects, and reduces inflammation. These are all the basic things we should remember that. Not only because of that, it is also reducing your postprandial triglycerides as well as your ApoE18 levels, ApoB448 levels, and all those things are going to come down. So the major thing is the semaglutide. So what is the dose you are going to choose? Start from 0.25 milligrams. You can escalate to 0.5 milligrams, 0.75, 1, and you can go by 1.7, and you can titrate the dose to 2.4 milligrams with semaglutide. How are you going to titrate? Make sure once in 4 weeks you need to increase the dose. Why? Because the semaglutide, even though when you are going to try this kind of molecules, very few papers for MASH. Recently for MASH, semaglutide, FDA got approved. They have been ready to try, but still not been fully available, fully acceptable. But still FDA been accepted to that to some extent for evidence of MASH and other things. And when you are going to use a semaglutide, the two major things you need to address. Whether the liver inflammation, the fibrosis is going to improve or not. With no major worsening of your inflammation pathway. Whether the liver steatosis is going to improve or not. With no major worsening of fibrosis. This is what we need to address with semaglutide. There is a trial what is called as Essence trial. In Essence trial, it's still going on. In that, the trial will come to an end probably by 2029. Almost around 240 weeks it will take its time course to get complete. So what is the main trial of Essence, which comprises of in the obese population, in the background of type 2 diabetes, in the background of liver fibrosis. If you are going to initiate the patient with semaglutide, we need to see whether the patient is responding to the treatment or not. But for the first 72 weeks of therapy, what they have been identified with this semaglutide, no major worsening of fibrosis along with steatosis also is going to get improved, and no major worsening of steatosis along with fibrosis is also going to improve. Almost around 30 to 60% of the population showed evidence that the patient is going to have a significant response with your semaglutide. That is one big proven. So far, only one molecule been approved by FDA for this fatty liver MASH. What is that molecule? Is nothing but your resmetirom. What is a resmetirom? It's nothing but your thyroid hormone receptor agonist, THR beta agonist. So once a patient is having, why THR agonist resmetirom being well approved by MASH? Because it will be having a direct effect on hepatic pathway. That's very important. Apart from that, the adverse events not much been documented, but for pregnant women, for immune syndromes, all these things we need to be very cautious when you are going to use your resmetirom. Another molecule what's called as saroglitazar, even then it's being well tried at a dose of around 4 milligrams at night when you are going to use. The major indication for your saroglitazar will be your diabetic dyslipidemia. And there is one more entity what is called as lean NASH. So what do you mean by that lean NASH? If the patient doesn't need, it's not compulsory for a patient who is having evidence of obesity to land up with evidence of your metabolic syndrome. No. There are some entities, even though if the patient is lean mass, because of the sarcopenic profile, the patient, there is evidence because of the inflammatory cascade which is going to get activated, the patient may still have worsening of liver enzymes. That's nothing but it's called as lean NASH. To a patient in the background of lean NASH, you can definitely consider saroglitazar as well proven molecule. But lean NASH, semaglutide is still being tried to consider, but need more data to approve. In the background of obesity, if the patient is having in the type 2 diabetes, in the background of liver fibrosis, in the background of metabolic associated steatohepatitis, the best kind of molecule to choose is your semaglutide. How does it going to differ from your tirzepatide? I will tell you a few key point of differences which you should not forget. Very importantly, semaglutide being in trial for more than 10 years is still more acceptable. But tirzepatide being proven only for 3 to 4 years of duration. So we need more and more data, we need more and more papers to support the beneficial role. Number one. In the background, for example, if the patient is having morbid obesity, for almost the BMI more than 30, if the patient has morbid obesity, if the patient is having fibrosis of F3, That's very important. I will tell you briefly about fibroscan. Very importantly, we'll be doing fibroscan to the patient most of the time if the patient is having liver fat. So once the patient is going to land up with evidence of metabolic steatohepatitis, which means the inflammatory cascade if it is at the higher side, if you are going to do a fibroscan, two major parameters you need to see. One is CAP scoring. What do you mean by that? Well, that's nothing but your controlled attenuated parameter levels. And next to that, your steatosis component, which means how much of fat has been deposited in the liver. So these two parameters nowadays you can well consider with your methodology, what is called as VCTE, nothing but vibration controlled transient elastography. It's also called as fibroscan. There are so many methodologies there to talk about fibroscan, various scoring systems there in liver disease. But very importantly, you should remember that there are so many ratios are there. One is what is called as AST to platelet ratio index. Very simply, you can choose your AST, you can choose your platelet score, and then with that we can able to identify with the patient. If the value of it tends to be more than 1.5, that shows the patient is having more worsening of changes. And there is one more scoring, what is called as ELF scoring. But it's more of research-based protocols for that. Nothing but enhanced liver fibrotic scoring. There are three major things we need to see for that. One is your procollagen, next to that your hyaluronic acid level, and another one is your tissue inhibitor of matrix metalloproteinase. These three enzymatic cascade, if you are going to see with that, if the value of it is going to be more than 9, which means the patient is having liver fibrosis. So there are huge list of scoring systems are there. I'm not going to each and everything. Very importantly, two major parameters, your steatosis as well as your CAP. If the patient CAP score, if it is tends to be more than 290, which means the patient is having F3 to F4 fibrosis. That's very important. If the patient, if the patient steatotic component, if it is tends to be higher side, which means the patient is having S3, S4, high steatosis, which starts from 240 to 290 to take into account. And I'm talking about this fibrotic scoring, which measures in values called kPa, kilopascals. If it is tends to be more than 12, which means the patient is going for evidence of cirrhosis. If it is tends to be more than 8, which means the patient is having worsening of your changes. Tends to be more than 8, which means the fibrosis has been taken off. And more than 20 and all, the patient is having significant portal hypertension. So there are the chances for this kind of patient to go for G8D. So we need to be very cautious when you are going to use. So F2, F3 fibrosis in the background of obesity,
Sir,
biopsy proven. Yes, ma'am.
I have a doubt. You mentioned about ELF score. What are the components you mentioned? One is procollagen, second is hyaluronic acid, the third one is?
Tissue inhibitor of matrix metalloproteinase, that's called TIMP. So metalloproteinase you can see in which, that is more of research methodology which not be frequently done in Indian scenarios. So you need to measure the enzymatic cascades. There are in research labs will be doing that. So these are all ELF scoring is one of the best line of score to identify that, but not doing in routine OP practice. That's why we are going to use it. That's why we are using indices what's called as your AST to platelet ratio index and so many other scoring systems. Your NAFLD activity score. By your simple liver biopsy, you can able to identify your steatosis, your histological changes, your volume degeneration, all these things you can able to identify by a NAFLD activity scoring index. That's what the huge list of scoring is there to identify this patient is having evidence of fatty liver disease is there or not. But importantly, the basic thing, your basic lab parameters with your CBC in the background of your LFT along with your fibroscan will clinch you most of the diagnosis to a patient nowadays without liver biopsy. But for this semaglutide, they have done for a patient in the background of liver biopsy proven patient. That's what they will mention in your essence trial. For a duration of time, they will be using the semaglutide molecule for almost around 70 weeks in the initial phase to see whether the patient steatosis is improving, your fibrotic changes is improving without major worsening of any other changes. And it has been well proven to some extent that the patient, almost around 30 to 60% of the population, will respond to your semaglutide. Fine. So what are the major adverse events when you are going to use your semaglutide for a duration of time? We are going to come across this. These are all the various benefits, that's okay. And adverse events wise, common symptoms like your nausea, your vomit, your loose stools, sometimes constipation. These are the basic adverse events being reported. Fine. Why means predominantly because of your prolonged gastric emptying. That is why most of the scenario, the patient, they will be giving at a lower dose. They will start the regimen only by 0.25 milligram. Just they will titrate the dose slowly every 4 weeks, and then they will maintain with a duration of almost 2.54 milligrams.